I came in for a kidney stone. CT scan showed an abdominal aortic aneurysm.
Aneurysms are described as silent killers. Patients unaware that they have a problem until they rupture.
It wasn't bothering me, it wasn't affecting me.
You don't have symptoms, you don't feel it. He had no idea he had this. This aneurysm could have ruptured when he was at dinner, could have popped when he was on the golf course.
And if they rupture, a significant percentage of patients are not going to make it.
Even if you are lucky enough to make it to the hospital alive, the treatment for an aneurysm that has popped surgically is a horrible catastrophic operation, so it's months to years of recovery.
One of the reasons I wanted to have this done in a minimally invasive approach is, I want that quick recovery.
The large majority of patients who have the minimally invasive repair go home the next day.
The eclipse is coming up on Monday the 21st. We're planning on leaving Friday, actually, the day after the procedure.
The last time we had a total solar eclipse that went from coast to coast was 99 years ago. The experiences are going to be amazing.
It's just going to be something very, very special on a very large scale. I mean, on a universal scale.
We're really talking about access to the body through a pinhole. And we'll use X-ray equipment to place this through the back into the back of the aneurysm.
So you can see how incredibly filled with blood flow that whole section is.
It'll take a little detective work to figure out exactly how to do this.
The blood vessel is so small that it doesn't want to go into it.
The risk was that we had to start all over and not be able to seal it.
If this was to rupture, the implications are significant.
This will be interesting.
That looks like a little bit of like a time bomb in somebody that might go off.
Just over 50 years ago, surgery was the only option for many serious medical problems. Thanks to some innovative doctors and their stealth approach, we now have the tools and technology to treat these problems using a wire inserted through a tiny pinhole in the skin. No surgery, no stitches, no scars. This is an inside job. By injecting dye directly into the body, they can see the unseen. Traveling through the blood vessels like highways, they penetrate the microcosmos of the human anatomy, offering big solutions without big incisions, expanding the realm of the possible, giving hope where there was none. This is the story of today's real superheroes, the inspired doctors who are saving lives and treating clots, cancers, disease, stroke, all without a scalpel.
So I think there's a lot of parallels between being in a band and being in a minimally invasive procedure. You have to learn how to deal with personalities that sometimes are under a lot of stress or a lot of pressure to perform. You've got to recognize the talents within each group and really let them shine. You need to allow the people to kind of push you to get better, to learn. Both require an incredible amount of dedication and practice, and I think years of experience really makes a difference.
I've been an OBGYN physician for 44 years. The most rewarding part, of course, is the obstetric part and delivering the babies, even the ones that come at 4 in the morning, because that's when they all want to be born. But it's something very, very special to be part of that new life, and it's just hard to put that into words.
Dr. Tom Phillipson's been a colleague of mine for a number of years, frequently consults myself and my group about minimally invasive procedures that can help his patient.
I think he's helped us save quite a number of lives over the last few years.
I became aware of his current issue with one of my colleagues from vascular surgery, and we closely collaborate on these aneurysm patients.
Last year in April, I came in for a kidney stone, and the CT scan showed an abdominal aortic aneurysm, which is a bulging of the aorta, the huge artery from the heart down to the lower extremities.
Abdominal aortic aneurysms are described as silent killers because the large majority are asymptomatic, patients unaware that they have a problem until they rupture. And if they rupture, a significant percentage of patients are not going to make it.
Being an athlete all my life, I kind of direct all of my attitude and actions toward that kind of competitive spirit. And I love golf. Golf is kind of my release, my outing. You know, I get on the golf course and every shot's a focus, and you're in that world, you live that moment. You hit the ball, and then the rest of the time, and you're hanging out and you're having fun, but you get up to the next shot, and again, you get in your own zone, you get in your own world. And I love doing that, and I do that with my patients in medicine too. When I approach a case, we talk about it, we go through it, but when I'm taking care of the patient, when I'm in the suite doing my procedures, I get in the zone and I focus, and every procedure I do is just like a golf shot. It's just focused on the patient, doing the best I can.
We've been married 54 years. We have 4 children, 4 boys. Different sports, baseball, football, basketball. She lived in the locker room for many years.
So Al is an avid golfer. He's an outdoor guy. Al had an aneurysm, a bubble in that blood vessel down in the pelvis, basically a bubble in the hose. And that bubble means that the wall of the hose gets thinner and thinner. So as that expands and gets bigger, the risk of an aneurysm is that it ruptures.
I think he was shocked.
I really didn't have any problem before. It wasn't bothering me, it wasn't affecting me.
And that's what they said, you don't feel bad with them.
You don't have symptoms, you don't feel it, you don't know it's there. There's no telling when they will go. We just know statistically as they get bigger, the chances get higher and higher.
If the aneurysm had ruptured and I wasn't in the hospital, then I think it's fatal.
It's usually catastrophic. The patient will lose blood pressure immediately, go down wherever he is. Even if you are lucky enough to make it to the hospital alive, 20 to 30% of those patients will still not survive that. And the ones that do, the treatment for an aneurysm that has popped surgically is a horrible catastrophic operation. So it's months to years of recovery.
Being at my age, you know, that could happen. Dr. Sewell wasn't sure at the time that we had the interview just what he would do, how he would do it, but it needed to be done, and we need to do it in a short period of time.
Well, once the aneurysm was found, I was given a choice of the old-fashioned open procedure versus the newer minimally invasive interventional radiologic procedure, it's night and day. I mean, it's a huge difference. The old-fashioned open procedure is a large abdominal incision, significantly lengthy surgery. It's probably 3 or 4 days in the hospital, at least 6 weeks of recovery.
I've been involved my whole career with treatment of abdominal aortic aneurysms, which have evolved from 100% open surgical repair with a lot of upfront mortality and morbidity to a minimally invasive procedure with significantly less risks for the patient.
The interventional procedure's been around for a number of years. They go through the femoral artery, which is the big artery going down to your leg, and thread a catheter and actually place an expandable stent that sort of opens like an umbrella.
Stents are a metal scaffolding. It really creates a pant leg or new plumbing that diverts the flow, takes the pressure off the aneurysm. And the aneurysm has branch vessels that supply the muscles in the back. 90% of the time, the aneurysm clots off after the minimally invasive procedure, but in about 10% of the time, those branch vessels can stay open and they can back leak into the aneurysm.
Yeah, a certain percentage of the procedure result in an endo leak that can continue to expand the aneurysm. The risk is rupture. It'll reach a point where it can't expand anymore.
After his repair of his aneurysm, the aneurysm had grown slightly.
Well, I got a call from my vascular surgeon, Dr. Engelbert, who said we need to treat this endo leak.
So the vascular surgical team referred him over for a minimally invasive repair. Treating a colleague or a family member or a friend adds a little more pressure, but I approach every patient the same exact way. We have a plan of action, we implement it. We don't try to change what we're doing based on how famous or how familiar a patient is. We base it on science. So Dr. Podolak, this is that case I was telling you about of Dr. Phillipson. This is his CAT scan, which shows his stent graft. You can see in the back of this aneurysm, we have an endoleak.
I see that. It sounds like we may need to perform an embolization, try to block off the blood flow to that area.
It's the exact same thing. Now, we could approach it several different ways. We could come from the back and place a needle right into the aneurysm.
That is interesting.
Once we get in here, we're gonna have to fill this space up. Some metal coils with fibers on them that cause the blood to clot, and then fill the rest of the space with some glue, and hopefully that glue will flow out into those arteries that are filling the aneurysm and plug it up that way.
That sounds like a great idea.
But the fact that he still has the leak, the aneurysm's still growing, if this was to rupture, obviously the implications are significant.
That looks like a little bit of like a time bomb in somebody that might go off.
One of the best procedures we do as interventional radiologists is aneurysm repair, fixing the bubble in the blood vessel. A story from the first patient I ever did. We did an endovascular, meaning an inside-out repair of an aneurysm, and sent the patient up to the intensive care unit after the procedure. The nurse genuinely called down to our room about a half an hour later and said, "When are you taking the patient for the procedure?" And Lord knows, she was so used to open aneurysm repairs who come back with the breathing tube in, completely out of it, in pain, taking months to recover. She didn't realize the patient had actually already had their procedure.
The difference between an open repair versus an endovascular repair is an open repair, patients under general anesthesia has a long incision in their abdomen, higher risk of cardiac complications, higher risk of impotence, higher risk of infection.
In Al's case, fixing an aneurysm, in particular that bubble, fixing that bubble in the biggest blood vessel in the body, the traditional surgical approach to those is a massive operation that would often require 6 to 8 months of recovery.
The procedure we're doing today with Dr. Sewell and myself is more elegant, more simplified.
It's a way that we can get inside the body and do things that traditionally required open surgery.
Less stressful on the patient as you approach the procedure by putting a needle into an artery, put a wire through the needle, put a catheter over the wire, and fix the same problem by working inside the artery.
Being able to treat him from the inside out is actually going to get him out of the hospital probably in 24 hours and up and doing normal activities within about 5 days.
Oh, good morning, thank you.
I think it's kind of profound. I've said this many times. I think it's good for a doctor to be a patient now and then.
Phillipson for IR.
Awesome. Well, welcome, Mr. Phillipson.
All the rigmarole of going through admission and explanation of the procedure, risks, benefits, and to be on the other side of the bed and understand how things are presented.
So that's the stent graft. That's taking away the majority of the flow, obviously. And there's the aneurysm. And there's the endoleak.
Okay.
The procedure we're going to do today is an endoleak repair, which is essentially plugging up the side branches that are still leaking into that aneurysm. We're going to use some minimally invasive techniques that involve some metal coils that'll plug the artery, and we'll likely use some glue, which will glue shut that leak into the aneurysm. So if we access it with a small needle through the back, then we'll be able to put some coils in there.
They have a number of solutions to block the artery, one of which is coils, which I can't even describe. I haven't even seen them.
What are the coils?
So the coils are platinum, and they have little fibers on them. Cause the thing to clot, and it also fills up space. These are essentially platinum wires that can be straightened and loaded into the catheter and then pushed with a guide wire. And then when you push it out of the end of the catheter, they rewind back into their predetermined diameter and length. And these fibers cause the blood to clot, clotting off the leak into the aneurysm. So these are very soft, very pliable, very pushable, and allow us to deliver them through really small catheters to get the job done. Hopefully that'll do it.
Yeah, how long does that take?
Probably gonna take us about an hour and a half.
We have guests coming over the weekend, you know.
All right.
Yeah, one of the reasons I wanted to have this done in a minimally invasive approach is, I want that quick recovery. The eclipse is coming up on Monday the 21st. We're having a large group join us up in Nebraska to watch it. We're planning on leaving Friday, actually, the day after the procedure. A very, very special event up there.
Well, this is an amazing opportunity. The last time we had a total solar eclipse that went from coast to coast was 1918, 99 years ago. We are having a total solar eclipse that's covering a huge portion of populated, accessible land. This is giving us an unprecedented opportunity to study, to look at the impacts on the Earth, to see the corona, and give us science like we've never had before. The data and the experiences are going to be amazing.
So in final preparation for this case, I'm going to review the CAT scan again. And a CAT scan is an image taken where the body is sliced like a loaf of bread in pieces. And as I page down, each piece is a section going lower and lower. The blood vessel we're working with is the aorta, which is this big tube coming down. As we get lower in the blood vessel going to his pelvis, we see a bubble in that blood vessel, which is called an aneurysm, which makes it dangerous in this case and why he's here for the repair. So in him, we're going to start on the opposite side, go up the healthy blood vessel, come around and go down into the area of the aneurysm. Our goal is to put a material-covered stent. It's an endovascular graft that we put from the inside out without having to open him up. The reason for doing this is to preserve blood flow to all of the organs, the butt muscles, and all the things that he needs to lead an active lifestyle. We want to get him back on the golf course and walking without the pain, the cramping, the things that would come from just blocking this vessel off completely. The complicated part about this one is that this aneurysm, this bubble, is acting a little bit like a sprinkler hose in that there are little branches coming off of it and one big branch. So we're going to extend our stent, our covered material, into the biggest branch, but we have to block off all the little branches because if we don't, they can actually bleed backwards into the aneurysm and still allow the aneurysm to fill with blood flow.
Drive like me.
I know.
So I think if we go in right at the L4 disc space, is there any other thoughts on it?
No, I think that's a great plan. I think we'll get it taken care of.
We have a signed consent for a indolink repair type 2 lapse today. Creatinine 1.16, INR 0.99.
Okay. I'll take some lidocaine, please. Thank you. Dr. Phillipson, you're going to feel a little pinch here. That'll go away here in a second. We'll get that nice and anesthetized. So I like to tell my patients I'm a human plumber. I'm usually trying to open up an artery or a blood vessel. We use image guidance, meaning x-rays, CT, ultrasound, usually accessing that occluded or bleeding blood vessel with a needle. Instead of an incision, it could be this long or this long. We're really talking about access to the body through a pinhole. In Dr. Phillipson's aneurysm case, what we'll do is he'll be on his belly and we'll use x-ray equipment to place this through the back into the back of the aneurysm, and then we'll advance a guide wire through that needle, which is a rail system. And that rail allows us to advance a longer catheter just about anywhere we need to go in the body. Base catheter has an angle that we can direct it into the area that we want to treat. And then through this base catheter, we can place the microcatheter, which is almost the size of a human hair. And the microcatheter, just like our base catheter, has a hollow interior. It allows us to inject glue. It also allows us to advance coils through that. And then as we pull the catheter out of the aneurysm, we can also plug up or embolize the little hole that we put in the aneurysm on our way out. So that really is minimally invasive.
As radiologists, we're trained to interpret images, but what that allows us in the procedure room is the ability to conceptualize in 3 dimensions exactly where in the body we need to get, yet at the same time, crossing all the specialties, be able to find and figure out the best way to do it.
Good morning. Doctor, how are you? I'm good.
In Al's case, fixing an aneurysm, in particular that bubble, the aneurysm which went down deep into his pelvis, which is a hard area to get to surgically. I am treating the internal iliac aneurysm, which is the big one, the one that we're worried about. And there are a couple of ways to treat it. And we're not, we never know 100%. We know what the plan is walking in the door, which is we're going to put that covered mesh material just in the branch where the aneurysm is and block off the little bitty arteries that could leak back into it.
Just stay all night, right?
Yeah, you're going to stay overnight. If things are good, we'll get you out of here.
Very good.
All right?
Sooner the better.
You got it. He had no idea he had this. This aneurysm could have ruptured when he was at dinner, it could have popped when he was on the golf course. Ultimately, if it pops, it causes massive internal bleeding and can be fatal.
Okay, you take care.
Okay.
Get some meat.
I will. See you later.
In the midst of physicians falling under burnout problems, working harder, working longer, doing all the things that make medicine difficult, I think interventional radiology is the place to go. I tell my partners when we walk in the door, the most important thing for us is that you love what you do and you love who you do it with. And as a group, we have that. More than any medical specialty, we have the ability to innovate, to design new things, to figure out better ways to fix things. I wouldn't trade what I do for anything.
Physician burnout is being recognized now as a really common issue. Medical school, residency, practice. Personally, I've become better educated on how to take care of myself. Being a physician that does procedures on patients is a big burden. It's a big responsibility, but it's incredibly rewarding as well. Music's been a big part of my life. It's a great stress relief. It's a way that I can be creative outside of the medical environment. Constantly writing lyrics and performing and practicing with my band, and that's been awesome. Well, there's a few things I can live without, but music's not one of them.
So in interventional radiology, one of the fun parts is that we work through pinholes. We pass a tiny needle into the blood vessel, and then through that tiny needle we can pass a wire. We can advance little tiny tubes called catheters, which are about the size of spaghetti noodles, over that guide wire, pretty much taking us anywhere within the body we need to go.
And then can we bring the monitor over us a little bit now? Thank you. So you can see how incredibly filled with blood flow that whole section is. So the big one coming out straight to the right side of the screen is the one that we want to go at. So now I'm trying to find the angle of the catheter that I think would best get into that little branch. You can see from that initial picture how many branches there are that we're going to have to try and block off. This will be interesting.
Trying to get to wires into proper branches, it's a challenge.
Guys with big arteries like him, sometimes doing it this way is a little bit harder.
But not for you.
So I'm ready for a microcatheter. So I'm in one of those branches that I need to close off so that it doesn't leak backwards. And we're putting in a little coil, and a coil is the equivalent of a bed spring that kind of curls up in the blood vessel and helps block it off. The pictures that we're using use X-ray dye, and the X-ray dye gets shown up as black on this image. And as we watch, you'll see this coil, which is straight in the catheter, but as it comes out, it's going to fold up into a little curlicue configuration. So there's how it comes out. It starts forming little curlicues, which is exactly what we want it to look like. So now my next branch is kind of right next to it, so we'll go back with the wire. Yeah, this looks great. So that, I think, takes care of those 3 branches in combination. Our goal here is to prevent back bleeding, so any kind of incentive to bleed will be cut down by those coils.
This is the aneurysm. These are the outflow blood vessels that are going into the pelvic area. These are smaller, so we shut them off by putting these coils inside of them. The stent graft will go from here into here and preserve this artery, but this is the only other branch artery that's coming off of the aneurysm, and we're worried that could that cause back bleeding, allow blood going back into the aneurysm. So it's a very small branch.
We had one other blood vessel, which basically took off in 180 degrees other direction from where we wanted to go.
It could bleed backwards and cause trouble. So we'll spend a couple minutes trying to get a catheter to make that 180-degree turn and get up and in there. That is a tough spot from this side to do.
One of the difficulties was no matter how hard we map it, no matter how well we plan with CAT scanning and all of our other guidance, once we get inside the body, sometimes it looks different.
Yes, I'm going to get a specific guide wire that has 2 different angles on it to try and make this turn. Even though it's a miniature catheter, the blood vessel is so small that it doesn't want to go into it.
So one of the hardest parts of the case and one of our aha moments was when we finally were able to navigate our little noodle catheter into that last blood vessel and block it off.
There we go. Okay. So wonderful we got into that horribly difficult artery to catheterize, but that's a big deal because that's the one last one I wanted to get.
That was kind of one of the cheer moments of the case, because if we couldn't do that, the risk was that we had to start all over and not be able to seal it.
All right, so we're loading the device. Basically a piece of bypass graft material mounted on a stent.
The bypass graft we put in essence, is what a surgeon would sew into the body. It's a piece of material, kind of like a Chinese finger trap.
So I think that's pretty good position.
This is the stent graft from here to here. So right now we're going to have to add on an extension. As the graft goes from this marker to this marker, the aneurysm ends here, we have to be all the way out to here.
So what we'll need is about 1.5 centimeters of overlap within the other stent to make sure that we've got room to seal there.
When we're treating an aneurysm, just like the bubble in the hose, there's a healthy piece of hose above and a healthy piece of hose below. And like a good plumber, we're basically relining across the aneurysm to create a healthy tube of blood flow that excludes the bubble from flow. So this is a good depiction of what we did on the patient. The aneurysm would be a little circle about there. The beginning of the blood vessel is where we tried to place the back end. This first stent, the back end of it is a little wider so that it can seal where the aneurysm is. The far end goes into a smaller blood vessel as we did. So the first device went in, but we thought that we were just a little bit short of completely and safely sealing the aneurysm. The second device is a little bit specialized. It gets loaded on a balloon. I can open it to whatever size I want. We put this device a little bit inside the other one so that we have overlap safety. So overall that bought us the extra length we needed, but the whole aneurysm was completely sealed by both of these together.
So this is the balloon inside the stent graft we just put in.
So you can see how this balloon just kind of molds to the size. And that is absolutely perfect. Yeah. That could not look better.
So the aneurysm now is sealed.
Everything went perfectly. We're closing this up, and then we're going to get him off to the table and on to recovery. Although he looks pretty recovered already. I did. I saw the kind of last hour of it, mainly because I played golf prior to that. But what a finish, huh? That was unbelievable. He had to make a sandy par on 18 to push it to a playoff, and then he holes out from the bunker in the first hole of the playoff to win it. It's crazy. Guys like Nicholas, Palmer, Tiger, people who dominated. It's mental, it's physical, it's all of it, and they got to have it all together. Everything's closed, we're all done. We're gonna let it hang tight, make sure it looks okay for a few minutes. He did beautifully. He's an ideal model patient. He's gonna come back and we're gonna do the other side pretty soon. Because that was so much fun. Dr. Walsh was great. We did well together like we always do.
Yeah, he's better looking than you.
I hope we caught that. He did tell me. So we're gonna get you up to the bed and we'll hang out for a little bit and we'll see you a little later, okay?
Very good.
You did great.
Thank you, doctor.
You're welcome.
That's looking good. All right, so we'll do one last spin here before we access the aneurysm. The procedure we're going to do to repair the endoleak on this aneurysm involves plugging up the two branch arteries that are still supplying blood flow to that aneurysm. It'll take a little detective work to figure out exactly how to do this, so we're going to start with a regular angiogram like you might have if someone was looking at the arteries to your heart. That needle is right, it's just in, isn't it? Just through there. So we're going to interrogate those arteries going to the aneurysm. Then we're going to figure out a way to get into those branches and plug them up, usually with coils or glue. That looks good. All right, so wire next, please. Okay, now I'm just going to go straight in like this, Travis. That'll give us the least opportunity to kink the wire. That's coiling in there.
Yeah, it is.
All right, so now we're right up to the aneurysm sac there. I can feel it going in. Wow, that's beautiful. Look at that. So there's the endoleak, very well circumscribed, and then you can see the two large lumbar branches that are supplying it coming off of the endoleak. Our goal is going to be to fill that and to fill those lumbars, and then we can put some coils in. Hopefully that'll take care of that issue. Really looks like a Medusa's head. Definitely not going to close on its own, right? No. We're going to use a liquid embolic, which is almost like an epoxy in that it comes out soft and then solidifies. It's called onyx. Okay, so here we go. We're going back, filling with the onyx. Next vial, please.
Out of here.
Okay, Tom, we're doing good. From the images, we can tell that we've got the onyx or the liquid embolic filling the endoleak completely. So now we're going to go ahead and use this guide wire to deploy a embolization coil right in the aneurysm. You can see it really well because it's made of platinum. It also has fibers on the coil to help the blood clot, so it's going slowly into the aneurysm there. Doing really good, Dr. Phillips. I'm just going to ease back a little bit here, Travis, as we put that coil right into the back of the aneurysm. There's a really persistent bugger in it. So there's the coil. You can see it real well. So I think if I could inject some onyx right there on our way out. Let me have that microcatheter back. We're going to put it right at the tip here. All right, now we should start seeing the onyx. There it is. Beautiful. And I think that is just at the exit of the aneurysm there. Look at that. All right, complete. We're done. We're pretty happy about what we were able to get accomplished. He's doing great. He's not having any back pain. That's a wonderful sign. So good. Thank you so much. Thank you. We're all done. You had two big branches feeding that thing, and it looks like we've got some embolic material right where they connect to the aneurysm. Hopefully that'll solve that issue. Feel all right? Beautiful. That's what I like to hear. All right. Awesome. I feel truly blessed to be involved in interventional radiology. I'm glad it found me because that is the natural evolution of medicine. It's going towards minimally invasive, it's becoming image-guided and more precise. We do biopsies, placing catheters for chemotherapy, very dramatic life-saving procedures such as repair aneurysms, treat bleeding and stroke. The field's constantly evolving, which is very stimulating when you're doing it for 25, 30 years. And it's really provided the juice kind of, to stay enthusiastic, involved, and continuing to basically grow as a physician.
There he is. Good morning, Al. Hi, doctor. How you doing?
Fine.
It's wonderful to be able to fix an aneurysm, get you back on your feet within 24 hours. That's pretty good.
That's
Yes,
good.
it is. And the aides were very good.
The nurses, the aides, the staff here are fantastic.
Yes, they are.
I asked the day nurse when she's getting off last night, I says, she's getting off at 7 o'clock. I says, well, give me your phone number. She says, no. I said, yeah, give me your phone number. If I have any trouble, I can call you. I listened to you quite a bit during the operation, you know.
Do you remember what we talked about?
Well, some of it I remember. Some of it I didn't recall, but I was surprised that, I wasn't out.
Yeah, and it's the ideal thing, right? Moderate sedation means you're comfortable, you're not in any kind of pain, but you're still aware and you still know what's
And I
going on.
didn't have any recovery afterwards with you do with a lot of this anesthesia.
Absolutely.
You know.
And that is a big deal. That's the whole basis of interventional radiology. What I do is that we can do it without the degree of pain you have with an open surgery. So it's just a little bit of sedation to take the edge off.
No, that was nice.
You may not remember, after the procedure we did on you, you kind of woke up and said, hey, Doc, can I play golf next Wednesday? It's the, Doc, will I be able to play the piano after I'm done? And it's, I don't know, could you before? Golf's going to be the same answer. You may not go down to a 0 handicap, but we'll get you on the course again. I am going to touch base with you soon.
Thank you very
Great
much.
seeing you.
Great.
We'll be in touch and we'll talk soon, okay? All right.
Cut.
You weren't supposed to say that.
One of the beauties of interventional radiology is that we are now pushing the envelope of advancing medical care. We're now doing things with less and less invasive approaches through tiny guide wires, through tiny tubes in the body. And I think over time, we're going to look back at some of our conventional therapies today, opening people up to do surgeries, giving them poisons to treat cancer. We may look back on some of the ways we used to treat patients and just shake our head and say, boy, aren't we glad we're where we're at now.
I expect to be back in a week and 10 days, be back to normal. I feel I've got, short of anything else happening, I've got a few years left.
Hey, Tom.
Hey.
How you feeling?
Yeah, I feel good.
Good.
Procedure was painless.
Fantastic.
Yeah.
That's exactly what I want to hear. I brought some pictures for you. You can see just how big that endoleak was. So that's that round ball we were seeing on the pre-op. But we hit it right, right in the sweet spot, right in the middle. That's exactly what we wanted to do. And then you can see all of this dark material is that epoxy or glue that we injected through the catheter. We put some metal coils in too. You can see those right here. They caused the blood to clot. Mm-hmm. We sealed the deal. I think you're good to go out and watch the solar eclipse.
Hey.
I'm jealous.
All right.
That's gonna be a once in a lifetime
Yeah, I think that's
thing.
going to be special.
All right, thanks a lot.
Thank you.
The eclipse is very special in a number of ways. It's been around for billions of years, and it's something that in a lifetime you don't necessarily get a chance to experience. I'll be 69 here soon, and I've never seen one. It's a wonder, something that scared the heck out of the humans for millennia, and it only lasts 2.5 minutes, the totality. It's just going to be something very, very special on a very large scale. I mean, on a universal scale.
Just now coming in, we have an exclusive sneak peek of the total solar eclipse, and it is arriving at the United States. This is the celestial event that we've all been waiting and anticipating for years.
You're going to see a total solar eclipse, which means that the moon is going to completely block the surface of the sun, and you're going to be able to see the solar atmosphere, the solar corona, with your own eyes. They will turn into night, which means the stars and the brightest planets are going to come out.
Let's take in the view. It's amazing, and it's spiritual, and it really brings you in step with that. We're just a small pebble on a highway of galactic endlessness.
I just can't believe we finally got a chance to see it. I mean, it's one thing to read about it, but it's another thing when you get to see it yourself with your own eyes.